Well, good afternoon. I really appreciate the opportunity to present what I hope is going to be a great opportunity for those of you who are interested in interventional trials or prospective cohort studies. Before I get started, I want to thank Dr. Belger for considering this opportunity and all her efforts at really bringing together what we do at the American College of Surgeons and the research community. So over the next 10 minutes or so, I will speak about how you could leverage the data collection that occurs for TQIP to support research studies. I have nothing to disclose. What I wanted to highlight are the specific advantages when you leverage existing data collection, and just think about how much data collection already occurs in your center. It can easily be used for research, and I'll speak about how that will play out. I will also give you a sense of the patient populations available for study through TQIP, just in terms of the proportion of patients and the absolute counts of patients who might have hemorrhagic shock or severe TBI. Many people like to focus on very specific patient populations for their studies, and this gives you a sense of actually who's available. I'll speak about the usual data flow and how we are going to modify that data flow for incremental data collection. And when I speak of incremental data collection, it's that little extra data that you might need to do your research study over and above what's typically collected within your registry. And then I'll speak about some enhancements that I think are very relevant to research. First of all, when you consider the amount of data you typically need to capture for interventional trials or prospective cohort studies, it's a lot of patient demographics, it's types of injuries, it's injury severity score, presenting vital signs. Well, frankly, again, 90% of the data that you might want for a study is already being collected by somebody else. And there are significant labor costs if you have to hire a research coordinator to duplicate that effort. So the leveraging of existing data collection is, again, a tremendous advantage. The other thing is when we see people developing databases for research purposes and to collect data, they struggle with, well, how should we define this? How should we define that? Where should we get the data from? Should it come from the nurse's notes, the ED flow sheet, the physician's notes? And how do we assure a certain level of data quality? Well, we've sorted all this stuff out already with TQIP. And we have, as you see, standardized data definitions. We indicate, where data needs to come from within the medical record and what is probably more accurate and what is probably least accurate, and so on. That's all been sorted out, so you don't have to reinvent the wheel. This is all sorted out through the National Trauma Data Standard, and every year this data standard is updated. This is essentially the data dictionary for TQIP. And when you're putting together your study, if you want to get a sense of what we're collecting as a matter of routine and how we define it, that's all in the NTDS, and this is available on the website, the ACS website. Just look up NTDS data dictionary and you'll find it. But this is how we assure that centers are using the same definitions across all our participants. It specifies the inclusion criteria for entry into the registry. And again, the data definitions. How do you define the ED admission temperature, for example? What happens if someone doesn't have an ED admission temperature until someone realizes it hasn't been done until an hour later? Does that count? What is the ED admission blood pressure? So all these things actually have a definition. The source hierarchy really speaks to where the information is most reliable and where it's least reliable, and how the registrar should be capturing this if the data is different in two different places in the medical record. And it also speaks to the data infrastructure to assure that whatever registry you're using, the data can still be sent to us. There's auto-calculated fields that are specified in the data dictionary. For example, you get age from date of birth and date of admission. And then there's a series of validation levels. So for example, certain data points, they might be out of range, in which case they can't be entered, or they might be unusual values, in which case the registrar is prompted for confirming that the data that they're entering is actually indeed correct. So there's all sorts of different levels of validation, some of which will prevent data from being entered. So if the data is way out of line, then that record can't even be submitted. So that's already incorporated into our data infrastructure. I won't go through this, but basically the NTDS fields speak to almost everything you'd want to know about a patient. I won't go through the details on the left, except to say that if you're looking for EMS data from NTDS, it is typically poorly populated. And I'll address how we're trying to deal with that towards the end of this talk. Hospital procedures are captured as well, typically through ICD-10 codes, along with the date and time of the procedure. I think if your study is very dependent on specific procedures, that I would probably create my own fields for that, so you don't have to worry about capturing the right ICD-10 codes. And we have selected process measures, like the timing of hemorrhage control, a lot of details about management of severe TBI and VT prophylaxis and early transfusion practices. And then we have a series of complications that we capture and very specific in-hospital outcome information. So again, this is all specified in the NTDS, and I won't go into too much detail. I will give you a sense of what's not an NTDS. So for example, if you're looking for the date and time of a hospital complication, did it occur before or after an intervention, for example? We don't know that. We don't capture CPT codes. We don't capture the cost of care, and we don't capture any data beyond hospital discharge. So everything stops on the date of discharge, which means we don't have late mortality and we don't have patient-reported outcomes. We're trying to address that latter deficiency, and again, I'll speak to that a little bit later. Okay, so who's in TQIP and who's in the NTDB? So TQIP is actually a subset of patients who are entered into the National Trauma Data Bank. The NTDB is basically anybody who is transferred, who's admitted to a trauma center, transferred to a trauma center, or dies at a trauma center, and who has a trauma diagnosis. TQIP has a little bit of more specific inclusion criteria, more restrictive. Adult TQIP is 16 or greater in terms of age, and you have to have at least an ISS of 9 or greater to be in TQIP. If you have an advanced directive that limits life-sustaining interventions, you're excluded. Or if you come in with no signs of life, you're also excluded from TQIP, but potentially included into the National Trauma Data Bank. So, we probably capture a good number of patients with TQIP who are entered into the NTDB, but not all patients, as you can see here. When you look at the numbers of centers participating, first of all states are represented. You also have some international centers from Qatar, from Canada, from Korea. But there's over 800 trauma centers represented and just over 500 adult level 1 and 2 centers and almost 150 pediatric centers. So again, you're getting great geographic representation. And this sort of speaks to the generalizability of any study that you might consider. Who are the universe of patients for interventional trials? Okay, so you're designing a study that focuses on patients with penetrating trauma or who present with hypotension. We have almost 300,000 patients entered per year, and you can see the breakdown. So blunt multisystem, which is defined as injuries within 2 or more body regions, looking at about 15% of the population. Hypotensive patients with shock and getting transfusion, only about 2.4% of the population is represented with those criteria. Severe TBI, isolated, 4.3%. If you take out the isolated requirement, then about 6.7% of patients meet severe TBI criteria. So this gives you a sense of what the typical sample size might be, and that's assuming you get all centers participating, which is unlikely. So the numbers get small pretty quickly, which is important when you're trying to define your inclusion criteria for your study. So this slide really speaks to how data flow occurs for the usual TQIP reports. So on the far left, you have registrars entering data into their trauma registry, and they typically submit data to us on a quarterly basis. That data is then all brought together in a large data set. We clean it, and it becomes usable data for the TQIP reports. If we wanted to add a field here or there for your study, it'd be very challenging because we have to change all those trauma registries, which really is very difficult to do. A number of different registry vendors are involved with this. And the timeline for this is probably 1 to 2 years to add fields. So very impractical for research studies. What we've designed, though, is a separate web-based direct data entry platform that is integrated within the TQIP data center. So basically, that means the registrars go ahead and collect their usual data, and just in parallel, your research coordinator or perhaps someone else in the hospital enters that little bit of extra data that you need for research, and ultimately the data actually comes together. So what does it look like? So here's the typical TQIP data collection. What you see on the left are different registries from different hospitals, and that all comes to us to the ACS data center as the TQIP data set. Okay, well, in parallel, you have a web-based data entry platform. IQVIA, you see there is basically our vendor. So they create this web-based platform, and there is an incremental data set that comes to us. So every hospital that's participating in the study enters their own extra data that comes to us completely separate from the usual TQIP data set. Patient records are linked by virtue of a unique identifier. And ultimately, we link the incremental data set with the TQIP data set, and that merged data set really is the research data set. So most of the data comes from the registrars. That little bit of extra data linked to the TQIP data set is the data that you're most interested in for your study, and that comes to you cleaned and available for analysis. This platform is very customizable. There's real-time data validation. So if you have restrictions on the type of data or the range, for example, of data fields, that can be incorporated into this web-based platform. And you can have free text, conditional text, which means you skip this field if this field is positive or negative, and you can have multiple choices and so on. As I mentioned, the data are aggregated across all the participating centers, merged with the TQIP data set, cleaned, and then returned back to you. And you can participate in several studies at the same time, each with a slightly different web-based, series of forms. And this is a typical form. This is a web-based data entry form, but the look and feel would be based on the type of study and the types of fields that you wanted to collect. So a couple of new things that are coming up. First of all, we actually have a platform that we're creating to capture patient-reported outcomes. So in this sense, the incremental data collection might be email addresses or contact information. We have this really now created for email addresses. If you have an email address for a patient, there's an automatic email that's sent to the patient so they can submit very specific instruments, whether you use the EQ5, SF36 or whatever. That data can ultimately be linked to the TQIP data and other research data. So there is a way of actually reaching out to the patient with this incremental data collection in the form of a PRO module. It's also possible to include patients who don't meet the typical NTDS or TQIP inclusion criteria. So we have this study underway that's sponsored by the National Center for Gun Violence, and it requires data collection on patients who are discharged home from the ED. Well, that's not part of the usual inclusion criteria for TQIP, but with additional data collection built into that incremental data set, you can actually include those patients. And ultimately, this is probably a few years away. I mentioned that the EMS data that we get is typically underpopulated, lots of missing data. We're working on a means of automatically linking EMS data from the National EMS Information System to trauma registry data so that we have a complete picture of what happens in the field. So again, that's probably a couple of years down the road. But the first 2 points are possible now or shortly within the next few months. So if you want to leverage this platform for your study, contact us. We'll help you write this into your grant. We'll work with you on designing the data fields and how the data fields should be validated. And we'll help you recruit the centers, explore sample size, and so on as you see fit. And with that, I'm happy to answer any questions. And again, thank you for your attention.